Good afternoon, everyone. Um, Welcome. Before we get going, I'd just like to begin by acknowledging the traditional custodians of the lands on which we're meeting, the Bidjigal people of the Eora Nation. Being from Canada, was not born here, and I'm just really fortunate to be able to work and live and play on these lands. And just to provide my respect to Aboriginal and Torres Strait Islander people who may be joining us on the call. All right, so some housekeeping to start off with. The format for this seminar is going to be two presentations, followed by a question and answer period after each presentation. You can ask questions throughout by clicking the Q&A icon at the bottom of the screen. So I think Rada is doing that, and we're good to go. It's my pleasure to introduce our first speaker. It's now Dr. Annabelle Stevens. Maybe join me in giving her a round of applause. So Annabelle just got her PhD last week, so it's all very fresh and just an amazing job. Pretty much, I don't know, I don't think I've seen this before. Maybe I have, but no corrections absolutely whatsoever. So just an amazing job on that. And just, yeah, it's a great work. So Annabelle, not only has she just finished her PhD, but she's also the manager of the Hepatitis Programs and Policy Unit at New South Wales Health. And it was just an absolute pleasure being able to supervise her PhD. And so Annabelle is going to talk to us a little bit about some of her PhD work, mainly focused around sort of different testing methods and how can we use different testing strategies to enhance hepatitis C elimination. So I'll give the floor to Annabelle.
All right, thank you so much. Thanks, Jason, for the very lovely welcome. It has been a bit of a whirlwind of a week, but feels really lovely being here today. So, as Jason said, I'd really like to just go through some of the findings from my PhD, talk about kind of the background and go into some of the findings. I too want to acknowledge the traditional owners of the land on which we're meeting today, the Bidjigal people of the Eora Nation, and pay my respects to elders past, present, and emerging. So I wanted to give a bit of a background on sort of what led to this PhD. Globally, Hep C continues to be a really major public health concern, with an estimated 56.8 million people still living with chronic Hep C. Luckily, since 2016, we've had fantastic treatments, and we've seen a rapid scale up of those highly effective treatments for Hep C. And we've seen some substantial reductions in Hep C prevalence. As you can see here from the Australian NSP's survey, we've seen RNA prevalence drop from around 50% in 2015 down to 8% in 2024. But despite this fantastic progress, we do still have over 60,000 people living with Hep C in Australia. So to understand why I'm focusing on testing, it's important to think about who is still living with Hep C. So Hep C is becoming increasingly concentrated among priority populations. We are seeing it among, obviously, people who inject drugs, people in custodial settings, and Aboriginal people. And although these priority populations are diverse, they do often experience really similar barriers to care. So some have poor venous access, making traditional blood tests difficult. Others may experience stigma or discrimination within the healthcare services, making sort of trust and a bit willingness to attend these services difficult. And others experience other competing priorities, so unstable housing, mental health challenges, substance use, or involvement in the criminal justice system. So why focus on testing? So traditional Hep C diagnostic pathways are often complex. They require multiple steps, whether it's the initial screening for antibody to show exposure to Hep C, confirmatory RNA testing, and then even further tests of liver function, co-infection. But every step along this pathway is a step that creates further barriers for people who already have existing barriers to care. So we're really lucky that we now have quite a few different testing technologies available. We've got dry blood spot. So DBS, as you can see there, is a fingerstick blood. We apply it to filter paper and then it's left to dry at room temperature. And once dried, DBS samples are really stable. So that means that they can be transported to the lab without the need for cold chain storage. And it's a really convenient option for services, particularly those with clinical capacity, low clinical capacity, long transport times, and high temperature environments. The other two that we've got there is point of care testing, and those are typically a range of tests that are available at or near the site where someone's receiving care. So it could be a hospital bedside, but more often it's a primary care clinic, community service, or outreach. We have tests that have really rapid result turnaround. They're portable, and that provides the ability to have same-day results, and hopefully, in theory, we can get same-day treatment as well, which is really fantastic. For Hep C, we've got the antibody tests there. We typically use the INSTI or the bio line with results within 1 minute or 1 minute or 5 minutes. And then the gene expert there is the RNA test with results within 1 hour. So again, by being able to have that same day result, it should allow also for same day treatment. But introducing these new tests doesn't necessarily improve outcomes alone. So the test might be accurate, but if the people don't want it, if services can't deliver it, or if it doesn't improve linkage to treatment, then we won't be able to achieve our elimination goals. And that broader question became the focus of my PhD. Excuse me. So the overall aim was to evaluate alternative diagnostic testing strategies across 3 different levels. So the first was at the patient level. So are alternative testing methods acceptable, and what do people prefer? Secondly, at the service level, how do these technologies perform when implemented in real-world settings? And finally, at the system level, where does Hep C infection remain concentrated, and how can we use this information to design targeted testing strategies? And that was answered across these 4 studies. So the first 2 focused on patient perspectives, evaluating acceptability of point of care and DBS, and evaluating testing preferences when people were given a choice. And then the other 2 were focused more on that real world implementation, evaluating the dry blood spot testing program and then analysing Hep C prevalence in the point of care testing program. Together, these studies provided evidence on not just whether these technologies work, but making sure that we can deliver the right test to the right person in the right setting to maximise our chance of the chance of diagnosis and treatment. All right, so the first study was on acceptability, as you can see here. And while point of care and DBS have really clear practical advantages, the implementation does depend on whether people are willing to use them and whether they trust these approaches. So we needed to understand patient acceptability among the people most at risk of infection. And we recruited participants through the Australian Hep C point of care testing program. And we did use this data for quite a few of the studies. So I'll just give a bit of an overview first on it. For those who aren't already aware, it's an observational cohort study, and it evaluates the scale up of finger stick point of care Hep C testing among people at risk of infection. Participants have been recruited across all states and territories, across 114 participating sites and over 500 testing locations. And inclusion in the program include people being 18 years or older, and then either at risk of hepatitis C or attending a service that provides care for someone with at risk for Hep C, as you can sort of see there, drug treatment clinics, NSPs, prisons. So back to study 1, we recruited participants through sites that were in the national program, and participants had experience with or were at risk of hepatitis C. And then we looked at their experiences, their perceptions, and their preferences on different testing, including point of care and dry blood spot. We analysed the interviews guided by Secon's theoretical framework of acceptability, which you can see here. And there are different constructs there. There's affective attitude, burden, ethicality, that all sort of provide more information about acceptability. All right, so looking at some of the results here, I'm just going to go into a couple of the key points. So looking at burden, overall point of care and DBS were found to be highly acceptable. They were easy, and participants, among those participants who had experienced the tests. But there was this anxiety or emotional burden associated with waiting for the test results among people who hadn't previously been treated. As you can see here from Michael, he says, "You don't want to wait, especially when I'm an anxious person. I reckon that's terrible waiting for a test, especially when you've shared needles." And so among this group, there was this really strong preference for receiving same-day results. With regards to the intervention coherence, most participants didn't have a preference, actually, if their test was done by a peer or a nurse, due to just that perceived simplicity of the test themselves. And this was particularly true if the test could be done in a service where they have an established relationship. As Josh says, it wouldn't matter as long as they know what they're doing. Flagging that this was not the case with venipuncture, as many people said they really wanted a highly trained healthcare worker due to poor venous access. And then also just looking here at self-efficacy. Interestingly, some participants really spoke about not being confident about a self-collected test or a mail service, for example, dry blood spot at home. And they really preferred assisted collection at a healthcare service. So as James says, I go into the needle exchange at least once a month or so anyway. So if I needed to do another finger prick test, I would probably just go through them. So this first study showed that overall point of care and DBS were really acceptable, but it wasn't just about the technology itself. So the way the testing was delivered was equally important. The consistent finding was the importance of respectful, non-judgmental care. And many participants described previous negative experiences with healthcare. And for them, the person delivering the test or the engagement and the environment was just as important as the test itself. So then moving here into the second study, the patient preferences, it built on that acceptability, but asked when people actually have the choice, which test do they choose? So again, this was a sub-study of the national program, and participants were recruited into the study and were invited to choose a test, complete the test, and provide the reason for their choice. They were reimbursed $20 for their time, and we then analysed the differences in the different test types that they chose, stratified by those with a history of hepatitis C and those with no history of infection. This shows the information sheet that we provided to participants to give them some information about what tests they could choose from. People who had previously been infected with hepatitis C, we assumed to be antibody positive. So we only offered them the 2 RNA tests, which is the dry blood spot there at the top and the gene expert at the bottom. And those who had no previous history of infection could choose any of the 5, which then also adds on the INSTI, which had the option of a self-test or assisted by a healthcare worker or a peer worker, and the bio line, which is also just the assisted option. So among those with previous exposure, so they only had the 2 to choose from, the gene expert was preferred. And among those with no history of exposure, so all 5, 72%, as you can see there in the green, selected the staff-assisted INSTI, followed by 21% selecting the staff-assisted gene expert. And the main reason for selecting the tests were the short time to result and the short time at the clinic. Interestingly, as you can see there, that first column, very few preferred the self-testing INSTI over the staff-assisted INSTI. This finding was really interesting to us because it sort of contradicts with some of the WHO self-testing guidelines, which are recommending self-testing for hepatitis C. However, looking into that further, it has been largely informed by some of the evidence from the HIV sector. So we sort of acknowledge that this is a different group with different preferences and behaviours, and potentially some further research is required to understand, does this group actually want self-testing, or are there some other options available? So overall, participants preferred the quickest perceived testing modality. Those were the ones that could reduce the number of visits available, provide rapid results, and include support from another person as well. And further research might be required to understand acceptability for self-testing among people who inject drugs a little bit more. But identifying these preferences with the acceptability of the first study were really important to be able to scale up different and appropriate testing models in Australia. All right. Study number 3. So the first 2 were looking at patient perspectives, but we wanted to also understand how these technologies perform when implemented in real-world settings. And so we evaluated data from the New South Wales HIV and hepatitis C dry blood spot testing program. So the DBS program was designed to expand access to Hep C testing among people who experience barriers to traditional venipuncture. It's run since 2016 and has supported the work that was done to get TGA approval of DBS in New South Wales. For this analysis, we included Hep C DBS testing data from almost 14,000 people across data from 2019 to 2023. And we included data from 36 community sites, a lot of drug and alcohol services, needle and syringe programs, and then also 21 prison sites. And we evaluated the prevalence of current Hep C infection and then also treatment initiation within 6 months of diagnosis, and stratified this by the community and the prison settings. So overall in this study, we found that approximately 11% of people had current infection. It was higher in community sites than in prison over time, but there was a decline in current infection over time in both the community and the prisons. And that continues to suggest that treatment scale up is reducing the burden of infection. The second important finding was related to treatment initiation. So among those with a detectable RNA, the community setting uptake was only 37% in comparison to the prisons at 64%. So for us, this really told us that testing alone doesn't achieve elimination, but we need to make sure that there are really strong linkage to care pathways. So in custodial settings, there's often more structured healthcare pathways with people easier to follow up, connect with treatment. While in community, we need some really targeted strategies to support people into treatment. We also identified some differences among population groups, and there were lower odds of treatment initiation among Aboriginal and Torres Strait Islander people in the community settings. So this highlights the real importance of making sure that we provide culturally safe care and models that are designed with communities. And the last one, study 4. So we moved from evaluating different testing technologies and moved into asking where should we focus our efforts if we are going to move closer towards elimination. So as Hep C prevalence declines, we need better information about where infection remains concentrated so that testing resources can be targeted effectively. The study analysed data again from the national program, and we included data from 2022 to 2024, with almost 11,000 people included in the analysis. And participants were included from community settings. So again, drug treatment, NSP, mental health, Aboriginal services, all of the community services in the national program. So overall, Hep C antibody prevalence was estimated at 36%, and current infection prevalence was at 8%. You can see the current hepatitis C status among our participants here. On the bottom is current infection. Then we have those who have cleared the virus with treatment, spontaneous clearance, and up the top is those who have never been exposed, so antibody negative. And current Hep C infection prevalence remained higher among those with history of injecting drug use, with increases with recency and frequency of injecting. Aboriginal and Torres Strait Islander people, those with a history of incarceration, and those with a history of opioid agonist therapy. And those are all identified risk factors. And so it just strengthens the evidence that we've seen about people at risk of Hep C. That says enrolled in the national program behind that icon there. But this then is the same, but looking at it by setting type. We have, though, also split up current infection into those with no history of treatment and those who have previously had treatment. And you can see there's really substantial variation between the settings. So current infection was the highest in services such as drug treatment clinics, community health centre and NSPs, which again reflects those sort of higher risk participants attending those services. And we also looked at the proportion of current infection among those with previous exposure to Hep C. So among the antibody positive cohort, what proportion had current infection? This was a new way of looking at the data and understanding potential insights into treatment coverage. And we saw that there was a lower prevalence of current infection among that group, among people that were tested in drug treatment clinics. And there was a question on whether that means that this group might be benefiting from the strong pathways into care that the drug treatment service offers, those embedded integrated care pathways. In contrast, we saw a higher prevalence in this group in community health centres and primary healthcare settings. And there was then the question of potentially these services are less clinically engaged, people are less engaged in the service, or maybe those participants have greater barriers to care. So this study found that current infection really did vary across different settings, which indicates there are some persistent gaps in care that we need to look into. Testing should be integrated and done routinely in our high prevalence sites, such as NSPs and drug treatment. But those lower prevalence sites we should be more targeted with rather than large scaling. large scale up, and then focus on those treatment pathways. But overall, making sure that we tailor our strategies to setting specific barriers and enablers to enhance that treatment initiation. All right, we're at the end. So bringing it all together, we do have a range of alternative testing technologies now for hepatitis C. Point of care and DBS have allowed us to move testing outside of traditional healthcare settings. We've been able to reach people who may not otherwise access care and reduce some of those practical barriers associated with traditional venipuncture. However, the impact of those technologies depends on how they're implemented. So we've got three key themes here across the thesis. So first, testing needs to be acceptable to patients. Participants showed that respectful, non-judgmental care, clear communication and support throughout the testing process were just as important as the testing technology itself. Second, at the service level, that testing needs to be connected to treatment pathways. So expanding diagnosis is only valuable if people are successfully supported to initiate treatment. And finally, at the system level, we need to be targeted with our testing strategies. As Australia moves closer to elimination, undiagnosed or untreated Hep C is going to be increasingly concentrated within different population groups, and we need to be smart about the way that we target our testing. So in conclusion, this thesis demonstrates that alternative testing technologies can play a really important role in achieving hepatitis C elimination in Australia, but that it's not just about the new tests, it's about implementing those tests within services that are person-centred, connected to treatment, and focused on the populations where Hep C remains concentrated. Together, these findings provide evidence to guide policy and practice as Australia gets to this next and hopefully final stage of Hep C elimination. But ultimately, that success will depend on delivering the right test to the right person in the right setting at the right time. And I just want to thank my supervisors so much. Thank you to Jason, to Alison, to Evan, and to Greg for a fantastic 4 years. And thank you so much. Thank you for the water.
Great. You did an amazing job at sticking to time. We've got about 5 minutes for questions. So yeah, floor is open. Any questions? Now you just moved it away further. my poor eyesight.
Brother.
Oh, well, we have to read this out. A very proud brother dialing in from San Francisco. Thanks for joining, Will. Dr. Annabelle, you mentioned the self-inst percentage surprised you compared to the staff-assisted. Were there any other surprises that came up in your PhD over the last few years? Great question, Will.
I hate that he asked a tricky question. It shouldn't be a tricky question, but I'm stumped at the moment. The self-testing one really wasn't a surprising one to me. I think the current infection among the antibody positive group was a new variable that we looked into, and understanding kind of how we could use that variable to tell more of a story of still high prevalence or at-risk groups, but where is there actually really good work already happening? That probably was a point that surprised us or was interesting towards the end of the thesis. So thanks, Will.
And just a comment from our friend Mitch Starr at St. Vincent. So just congratulations, Dr. Stevens, an important contribution to Hep C healthcare. Oh, thanks, Mitch. Anybody else in the room would like to ask anything? Thinking, you've done all this sort of work. What are you sort of thinking next? What do you think next needs to be done?
I think that targeted into the right settings is really important for us. I think every day at the ministry, we're talking about sort of how do we make sure that we're finding the right people, because it's getting harder and harder. And so looking at the data and being really smart about what's working and what's not, I think is what we need to be doing. So if we're not finding people in mental health services, then let's stop testing there and let's actually put the resources, which are reducing every day, let's put them into the right places so that we can actually get people into treatment.
Awesome.
Congratulations. That was great to see all the outputs. I just targeting implementation going forward. As a health economist, I think about the costs of doing that because it gets more and more expensive as you try and get more and more targeted often. Do you think that we know enough about the cost effectiveness of strategies going forward, or is that an area you think we need to sort of do more in. Thanks.
Well, there's some really great work. I think that's already happening in that space. I am not a economist, so I'm not that person, but I know Ching Lu's been doing some fantastic work, and Sophie and Jason's team. So I think some of that will come out, and I think it's really important. I just had a question today from one of our LHDs asking that exact question. So I think that research is going to be really important to have understand that as the purse strings are getting tighter.
Great. All right. Well, want to make sure that there's equal time, but just fantastic job, Dr. Stevens. Great presentation. And yeah, thank you so much.